My name is Nick Maxfield. I'll be moderating today's session and I handle the Van der Schaar Labs communications. I'm also joined by Michaela Van der Schaar, who will be responsible for the roundtable and the Q&A. And we have with us today a panel of 4 clinicians who will be kind of doing the substance of the roundtable. So to give you an idea of what to expect from today's session, as always, our purpose with Revolutionizing Healthcare is to build a shared community and develop a common language by defining and understanding medical problems through the use of formalisms and by mapping these to AI and ML solutions. Our previous session, as many of you will remember, was a roundtable on interpretability. And last time, we kind of extended the roundtable to cover the whole session because it was particularly insightful and useful, and we decided to move the Q&A to this session. So this time around, we're going to build on that previous session, hopefully deepening our discussion on interpretable machine learning for healthcare, and also incorporating the Q&A from the previous session and a new Q&A for this session. And just a kind of reminder, this is a relatively new format for us. We're not quite used to roundtables yet, so it may get a kind of little chaotic at times, but please bear with us and we'll try and bring things back to normal. So to break this down for you time-wise, we're going to start with an intro from me and then go into a kind of brief recap of our previous session by Michaela. Then we're going to move into the substance of our roundtable with our panelists really and incorporate some of the questions we received last time as well as some that we received via email since then. And then we're going to go into a kind of open Q&A and discussion. So please feel free to post your questions for Michaela or our panelists into the Zoom chat, but please don't message us individually. Please post them to everyone. Please, do feel free to share your questions at any point in the session, not just during the Q&A. In fact, earlier is better. And do let us know if you think you'll need to leave before the Q&A session, in which case we'll read your question out for you. We do want to limit ourselves, if possible, to questions from practicing clinicians, if that's okay. And we expect to probably wrap up at about 5:15. Okay, so next up, please let me introduce our panelists for today. You may recognize 3 of them from previous roundtable and from all of them, in fact, from previous Revolutionizing Healthcare sessions. So we have Alex Gimson, who's a consultant transplant hepatologist with Cambridge University Hospitals NHS Foundation Trust. We have Henk van Weert, who's a professor in general practice at Amsterdam UMC, where he's also involved in research programs in oncology and cardiovascular diseases. We have Martin Caderas, who's an associate professor and medical director in heart failure, heart transplantation, and mechanical circulatory support at UC Davis. And joining us for the first time for this roundtable series, we have Maxime Cannison, who's chair of the Department of Anesthesiology and Perioperative Medicine at UCLA. But before I go any further, I do kind of need to give a quick little disclaimer about these sessions. So as many of you know, we can now award continuing professional development credits for UK-based clinicians under the Royal College of Physicians scheme. So this is 1 credit per session you attend. But in order to do this, I need to make a quick disclaimer to the effect that this is a non-commercial, no-fee event organized by our lab independently from our research sponsors, that we have no conflicts of interest, such as financial relationships that would undermine the balance, objectivity, or scientific rigor of these sessions, and that we won't use these sessions to promote products or services. If we do mention one of our sponsors, it'll be strictly relevant to the session's academic context, and we'll acknowledge a sponsorship when such a mention is made. If you do want to know how to claim credits, please stay to the end of the session and I'll explain at that point. But next up, we have our kind of intro from Michaela, and she'll be talking about basically what we covered in our previous roundtable session.
So thank you very much for joining us again today. I would like just to briefly recap some of the terminology that I've introduced in the past Revolutionizing Healthcare, because it may be useful for the discussion today. As I mentioned last time, we have 2 different pillars that are working together. One is interpretability, where we take a learning model, a black box model, and try to understand why this black box model issued a particular prediction. Then we have explainability, which is slightly different. And the focus is, what can we learn from the model? And then we have really different types of explainability, for different types of stakeholders. For instance, for the clinician, we may want to know why a particular recommendation was made for the patient in front of them. For a researcher, they may be interested in a hypothesis that was generated by the black box model. And a patient may want to understand what characteristics of himself or herself has put them at risk, but also what they can do to lower the risk. So what particular variable that's hopefully actionable for them, they can act on to lower the risk. I have introduced at the time 4 different modes or types of machine learning interpretability. The first one was looking at explanatory patient features. What features are important for the model, for the black box model when issuing the prediction? The second one was learning what similar patients have had a particular, have led to a similar prediction, and what patients that are seemingly similar have led to a very different prediction by the black box model, such that somebody what made them be different than other patients that may look somewhat alike. The third type of mode of interpretability is trying to learn some type of laws or hypotheses as to what variables were important and what would be needed to flip the prediction that's made by the black box model. Finally, the most comprehensive mode of interpretability is through transparent risk equations that we can obtain on the basis of black box models interpretability. So again, the first type of interpretability was identifying features that were important for the black box model when issuing the prediction. This can be done either at the population level, global level, or individualized level, patient level. And the example that I gave was in the case of breast cancer, the black box model may issue a prediction for breast cancer mortality within 1 year. And somebody may want to understand and interpret this black box model's prediction and may learn that, for instance, for this patient, it is these 2 variables that were important. And potentially for another patient, other set of variables were important. One of the methodologies that can do that at the individualized level was developed in our lab and is called InVase. And I showed an example of how InVase can work. So we have here the prediction of risk of mortality for the patient over time. And what we saw is that somebody can understand these predictions by looking at variables and variable importance for this black box model for this particular patient. And you can see that in this way, you can identify features that are very important for the patient, features that are of medium importance, and features that are of minimal importance as identified by the black box model. The second type of interpretability was based on similarity classification. And again, here what one can do is can try to identify for the black box model, which other patients from the corpus of historic patients or the patients that a particular user wants to present to the black box model, what other patients may lead to a similar prediction of mortality as the patient at hand. So if Nancy, we try to explain the predictions that are made for Nancy, we can look at patients similar to Nancy that were having a similar prediction and patients similar to Nancy that have a very different prediction. So it is through these similar and dissimilar patients that we can find another type of interpretability. Then the third type of interpretability is through unraveling some type of laws or rules. Again, somewhat similar to a Bradford-Hill criteria in medicine, we could try to identify counterfactuals or rules as identified by the machine learning model. One way to do these counterfactual explanations, this is not the only way, but it's one possible way, where we can describe for a black box model, for a particular patient, what is the smallest change we can do on this patient's features that will change the machine learning prediction to a particular output. So for instance, The current prediction for Nancy is of dying from breast cancer of 0.28 in the first year. If we want to reduce this number to another value, what features we will need to change? And are these features potentially actionable? This would be one way in which this type of interpretability would work. The fourth type of interpretability is probably the most comprehensive. And here we are going to approximate a black box model using a transparent risk equation. And similarly, like for regressions, we have a transparent linear risk equation. In this case, we are going to have a transparent but nonlinear, potentially nonlinear risk equation that will approximate the black box model. So in this case, we are as interpretable as regressions would be, with the difference that we will have nonlinear terms in the transparent equation. So the example that I showed was this use of meta models, where we can approximate a black box model through a symbolic meta model, thereby turning it into a transparent risk model. The example that I gave was, for instance, for prediction of breast cancer. Again, we know that black box models like autoprognosis, which we discussed in a previous Revolutionizing Healthcare session, are significantly outperforming existing state-of-the-art risk scores in breast cancer, but unfortunately they are black boxes. If we want to approximate this black box model autoprognosis with a white box equation, we can do that using meta models and have a risk equation. Here is just a toy example, which approximates the black box model and leads to a slight reduction in performance, but with the advantage that now the risk equation is available. And we no longer need to use the black box model. We can rely now on this white box model to issue the predictions. I mentioned that these transparent risk equations are very useful because all the different types of interpretability described previously can be recovered using these transparent risk equations. For instance, we can have type 1, 2, or 3 interpretability using the white box, using the transparent risk equations. And also we can issue counterfactual explanations using transparent risk equations. So if one is able to use this type of machine learning interpretability, one has the benefit of recovering all sorts of interpretability types, as described before. So now that I introduced the terminology, we resume our discussion of last time.
Okay, so just to start us off, we have a few questions that we received in our previous session that we didn't manage to get to, of course. And I think we can kind of dispatch these relatively quickly in a sort of quick fire way, but they're from Anik Remen, who posted into the chat last time. 3 questions, I'll just go through them one by one. The first being, does Invase work with deep learning models?
So the answer is yes. These methodologies for variable importance and either at the personalized level or at the global level are working post hoc. So this means that I can take any black box model, whether it's a random forest, an XGBoost, or a deep learning model, and I can interpret it using Invase. So the answer is yes. Any black box model can be interpreted with Invase. Okay,
so his second question was, does interpretability lead to overfitting in ML models?
So again, this is not the case. The black box model was already trained, and one, of course, needs to train appropriately to avoid overfitting using all the regularization methodologies. But then as soon as the model was trained and validated appropriately, one can interpret it in a post hoc manner. So it is not that we are training these interpretability models jointly with the training of the model. The model is first trained, and only after the model has completed its training, we are interpreting the black box model using these methods. So it does not lead to overfitting. It doesn't do anything.
And the third one, a little longer, is my general concern with this interpretability approach is the sample size of certain cohorts. We must remember that ML and AI is limited to data. For cohorts of patients with rare diseases with not large enough sample sizes, interpretability and ML models may cause a lot of false positives.
So again, this is a misunderstanding. Of course, machine learning models may not perform well in the case that we have few samples. So if the sample size is limited, if the cohort is small, machine learning models may not perform well. That is a problem of machine learning models, has nothing to do with interpretability. Interpretability could just expose what the machine learning model has learned and possibly wrongly learned. So I would argue that if you have a machine learning model that was trained on limited data, you may learn potentially associations or relationship between features that may not be there. This can be exposed by the white box, by the interpretability modules, but has nothing to do with the training of the model. It is separate.
Okay, fantastic. So next, we're going to go to a few questions that we sort of received by email between our last session and this session. The first being from David Chong. So David, I think, actually has two questions. One that's maybe a little bit more directed to you about methodologies, and one that's more about applications that I think maybe we can give to our panel. But David, if you want to unmute yourself and maybe start with the first question for Mihaela, and then we'll do the second question, which can be for our panel.
Okay, hi. Yeah, so from the previous session, I think one of the panelists mentioned that from lung cancer, like one of the models predict like you ranked incontinence as quite an important feature. And then he reconciled that with the fact that if you have lung cancer, you cough, and then therefore you have more incontinence. So I feel like this is sort of one step beyond like interpretability, and I was just wondering whether there are methods which machine learning could like develop these kind of hypotheses.
So thank you, David. So this is more or less what I was trying to say through explainability, going beyond interpretability. So to some extent, these interpretable methods are showing relationships between variables. Let us take the last type of interpretability, the transparent risk equations. Then you have an entire equation, if you like, which looks at the different variables and how they interact with each other to issue the final prediction. This is a hypothesis that is learned by the black box model. Then a clinician or a medical researcher will need to look at the resulting hypothesis and validate it. So one could use these tools of interpretability to generate hypotheses that clinicians and medical researchers can take to their lab.
Okay, shall we go into David's second question, which is maybe the one a little bit more for some of the panelists as well?
Yeah, so I'm currently like a final year medical student at Cambridge, and what I've seen so far is that in clinical medicine, there's a lot of scoring systems that we use, and in a way, like from day to day, we use them quite a lot, like as black boxes anyway. So I'm just wondering, like, what is the, like, are we having like different standards, and like for scoring systems versus like AI models and things like that?
So I don't know, Hank or Martin, if you want to take that, or Alex.
Well,
Hello.
maybe the question should be a little bit more explained. You ask for whether machine learning can introduce new scoring systems, or did I understand wrong?
I'm basically saying that like from day to day we use like various scoring systems like the QRisk or the Glasgow score and we don't necessarily always look into detail about like how these scoring systems may work, or maybe when we and we may not use it to explain it to patients all the time. Like sometimes if it's relevant, we might. So I was just wondering, like in terms of AI models, like how do you feel that interpretability and explainability will fit into clinical practice at that point? Since we don't use it all the time anyway, I feel.
Yeah, well, I just can give you my opinion on that. Because what I do think is that if he can explain to a clinician how things work, he will be more inclined to use it. And if you look at scoring systems like Q-risk scorings, or also the work of Willie Hamilton, for example, it is quite clear that his or the scoring system for Q-risk, they have some clinical evidence in it. And I think that for the use by clinicians of a scoring system, that's very important, that they can a little bit understand how things work. If you have the example of urine incontinence I used, because that was a thing that I saw, and then you have to be a clinician to understand why urine incontinence can have a relation with lung cancer, because that's not obvious for anyone else. And as long as you can explain it that way, I think I can make you believe that incontinence is linked to lung cancer. And if I wouldn't have any explanation for that, you wouldn't believe me, I think.
Martin, you wanted to also
is that some sort of an answer?
Yeah, to an extent. I have more questions, but I'll save it for later. Yeah.
Okay.
So Martin, did you want to say something as well?
Yeah, so I think, I mean, it comes a little bit of how we use how do we rely in those models as the ones that you referred to. I mean, in some ways, like when we think it's a solution that fits everybody, right? So we are trying just to apply the same model to an entire population, and that model is derived from a large population of typically patients that come out of a registry or clinical trials. So that leads, like whenever we're making a decision, we're assuming that that patient is similar to that specific population, and that we rely in the ability that has that specific model, not just to make a prediction. So I think as far as I think we are doing our interpretation, and we know our limitations, right? Like, for example, let's get the MELD score. We know what the creatinine, what the bilirubin is for a patient. And we use that in our heads just to interpret. The thing is, the assumption that that MELD score applies the same for a wide population, where there's a lot of variability, where there's like groups within this population or clusters that, I mean, they not perform that well. I think that's where understanding of how our machine learning algorithms perform, it's part of that benefit that I see.
If you allow me at this stage, I would like to introduce Maxim, because I think it's the right time to kind of maybe to continue and steer a little bit the debate. And I'd like to if you allow me, share a slide which represents a paper that Maxim has written quite a lot of years ago. So, and the paper is very nicely called "Boxes Are Black." And he says, and allow me to read this. So I took some parts of the paper. We should at least have a superficial understanding of how basic technologies work. However, very few of us could explain how an automated blood pressure cuff determines systolic, diastolic, and mean blood pressure. Few clinicians have the expertise in signal processing to know whether the algorithm that converts physiologic signals to clinically interpretable numbers is good or bad. Not understanding the signal processing algorithms, we may disparage using black boxes to support clinical decisions. In his debate with Barker, Shelley says, "I personally will not allow black boxes into my operating rooms." We are concerned that Dr. Shelley will be standing in the operating room with his stethoscope and little else. The clinical testing of an algorithm is necessary and sufficient for clinical use. That is the regulatory perspective. That is the clinical perspective. That wins. So I'd like to ask you, Maxim, maybe to say a few words about this, and whether you still believe that this applies, and whether you believe this applies to machine learning.
Well, Okay, thank you, Mihaela, for bringing this up. So the first thing I want to mention is that, so I did not expect you to present this today. I know you knew the paper, but so this paper was more like an academic exercise, right? With a pro and con it was about disclosure. When I hear black boxes, as opposed to a white, or you say transparent or opaque box, or closed versus open, whatever. So it's about the disclosing what's in the box. And disclosing is about disclosing the intellectual properties. So you have disclosure that you need to disclose the way technology works, but a lot of time these technologies are not disclosed because there is IP that's protected, but it's also disclosing how it works at the root of the technology. And a lot of clinicians would argue that they need to understand how technology or medication work in order for them to accept it. And my argument in this manuscript was to say, you know, most of us do not have the expertise to understand how most of the technologies we are using actually work. Something as simple as the pulse oximeter with red and infrared absorption and everything, the way it's computed, the way the number comes on the screen and everything. Most clinicians wouldn't know how to explain it, but most would be okay to use it. So when it comes to machine learning algorithm, that the question is going to be the same. Do we really need to know and understand how this system works in order to accept them? Or is the clinical testing the only thing that's going to make this system be accepted, be efficient or not? I believe the clinical testing is going to win. I think that's going to be much more important to actually understanding how this system works. And also believe that if we really want this system to be understood by clinicians, what we need to do is to increase the level of medical education around technology. We go to medical school, we've gone to medical school, people will go to medical school, and we'll keep on learning about physiology, about pharmacology, about anatomy, and they will practice in a world surrounded by technology, and they will have no clue how this technology works because there is absolutely zero education about medical technology in medical school. So I think the long story short is that should we understand how this system works? Maybe, but more importantly, we need to understand, in generally speaking, how technology function and have teaching about technology in medical school, so that at some point, if we really want to explain people how it works, they will be prepared to understand how this system works. Because today, even if we were to disclose what's in the box, I'm sure the vast majority of us would not understand how this system works.
So this is very interesting, Maxime. I kind of would like to almost ask Alex, Martin, and Hank whether they have any comments or any thoughts in response to this.
I mean, I can maybe say from my standpoint, I think like one is the interpretability, and then what is the degree of interpretability probably. Because one thing, like for example, every day we run in front of an alarm in an intensive care unit, right? So that is based on an algorithm that has learned and say, well, this patient has ventricular tachycardia. Most of the time, those are false alarms. So if I don't have my interpretability, right, then I would say this is ventricular tachycardia, and that's going to be my assumption about that patient. And like this, there are many situations, right? So I think I don't need to know. I mean, I trust the machine learning specialists on how are these equations in order to derive this, and know that there is a process which is a derivation and a validation, and that there have certain operating characteristics for the measures that we have. But then it's on us on how do we interpret the data that we get out of there, right? So because it's very different if I have certain risk features in order just to make a decision about my patient. Like for example, I had to make a decision today on a patient that is ventilated. That's part of a risk model. whether the patient is diabetic. I approach that patient 2 different ways. I know that my patient that is ventilated, the risk is much higher than if it's diabetic alone. So I think I agree. We don't need to know everything and just keep it as a black box. But we know because we have some trust on that black box. But we need interpretation in order to avoid. Yeah, I mean, avoid incorrect interpretations.
So you would say, Martin, that you need the interpretations to make sure that it's a correct usage of the black box as well.
Correct.
Would you say that? I don't know, Alex or Henk, whether you have anything else to add.
Well, I agree very much with Martin. There must be some clue for a clinician that how it works. And I also agree with Maxime, because none of us has any good idea anymore how an oxygen such a machine to measure oxygen works. Nobody knows, and we all use iPhones, and we don't know how they work. And still, we are sure that I can speak to you through an iPhone, as I do now. So there's no mistrust in that anymore. But you have to have some, I think, as a clinician, because you are you're doing things that you need to explain to other people, namely your patients, why you do those things. And if you just can't tell, well, my algorithm tells me to do so, I think that's not enough. So you have to have some cue or some clue why the algorithm does what it does. And if you don't have a slightest idea how it works, you will not use it, I think. I think clinicians will not use things they don't trust. And you don't trust things you have no clue on. I think it's a normal human idea, human thing. Yeah.
But if I
Sorry,
would
my English isn't always that good. So
if I would ask all of you, so all our panel or everybody, what would you find sufficiently interpretable? Would you like to be given this black box model and these various interpretations, and you see almost like testing period, you know, kind of alpha testing or beta testing, where you will take this model and despite the fact that maybe has been certified, you would play with it and you would be given a tour of what it can do, and then you can decide to deploy it? How do you envision using this interpretability methods? Would you need to be taught to use this black box? Would you like yourself to play with it? I remember in a previous discussion with Martin many years back, Martin said that he tells me something I've never thought about. What would you like to hear from the interpretability model to make you use it?
I think there are a number of components of trust which humans need, and not just for using technologies. And all the different components are necessary, but none of them alone are sufficient to generate trust. I mean, we do need to have explainability. You do need some degree of transparency, but I think depending on the context, depending on the situation, you know, the degree of transparency behind it may vary. You may need to be more transparent in certain contexts when it has got a really, really critical role, and less transparency when it has a less critical role. I think for many clinicians, the empirical value of the technology has an overriding, if you know that it has been shown to be beneficial, then whether, like the pulse oximetry, you really understand the algorithm behind it, I'm not sure matters. I think lots of other things, I mean, on a more sort of much deeper level, I think peer pressure makes a difference. You know, if you see everybody else using it, then you're more likely to use it yourself. So if it comes with a prior reputation, then you're maybe more likely to use it. So these are lots of things which persuade us behind to make, because all the decisions we make about technologies are not entirely rationally driven. Some of them are to do with our current cognitive biases about certain situations.
Yeah, I'd like to follow up on this, because I think one of the key words when it comes the key word or the cornerstone of what we are discussing here is trust. And the question is, how do you establish trust?
Yes.
And there is a part of trust that you gain with intelligent, reasonable explanation, but you have a part of trust that you gain by the demonstration of how you've developed a relationship, right? And so it's the day-to-day demonstration of your value, the way you interact with someone. I believe, for example, the way these systems are going to be trusted is it's going to start from the groundwork, the foundation. Do you pay attention to the ethics of developing algorithm in a big data environment? Are you going to include a population of patients that reflects the population of patients you're going to take care of? Do you take things like diversity of your patient population in terms of gender, race, ethnicity into account when you develop? If you don't, you're going to breach the trust. Then the next step is, how are you going to develop? Who are the people, the developers, the engineers who are going to be part of it? What level of ethics they've demonstrated in the past? What kind of team have you built around to develop this algorithm, to avoid biases and things like this? And then you build on this trust. I think that's the first thing. And the second thing is there is something to me that's irrational, that I don't know how to do that, is on the predictive modeling, is the practical implementation. So you're going to give this system to clinician, and let's say this system is going to tell you this patient is at risk of dying in the hospital in the next 24 hours or 48 hours. So you identify it, you do something about it, the patient doesn't die. So you could argue retrospectively the prediction was wrong, right? How do you know whether the prediction was wrong or whether the prediction was right? So I think the clinical implementation of this system will have to be extremely well-defined, with shadow period, where the system made prediction without intervention from the clinician, and then you show this is what the system would have predicted. Then a second step of implementation. So the implementation science of this algorithm is going to be extremely important.
Maxime, sorry to jump. I apologize, Alex. Sorry to jump here, Maxime. This is wonderful preview to a session we plan for next month, where we are going to talk a lot about counterfactuals for treatments. What would have happened to the person if we would not have treated in the current way? So maybe we can address that in the session next week, when we are going to look not only at what happens given current decisions, but what would have happened if we would have acted differently. So kind of what you are saying, Maxime, would be that you would need such treatment counterfactuals to make you confident that indeed, by acting in this way, you did save that person's life and you would not have had otherwise. So maybe these modules will need to kind of work together. Sorry, Alex, I interrupted you.
No, I was going to agree with Maxime. I think this is a topic we have discussed before. Depending on the approach, the personality of the person who receives a certain prognosis, it may make them work harder in order to try to counteract that prognosis, or it may make them actually do the opposite and say, well, the prediction is that this person is going to die, so I will do even less. And then for sure, that confirms the prediction. So how we interact with these prognostic scores, I mean, these technologies is crucial in their clinical utility.
And this is where, again, I would say machine learning needs to evolve to have the human in the loop. So currently kind of a frontier, which both of you are highlighting, is the fact that we cannot just train these methods in isolation of their use. Yes, we can do, like Maxime rightly said, some type of almost mini tutorials or period in which we are going through a set of examples that can be highlighted to the clinician and they can learn how to use it, followed by maybe building trust as the system is used. But like I think both of you are saying, this will impact how the clinicians will react to this course and these tools, and their decisions may be altered in this way, which would lead to kind of a need for new systems to be trained knowing that type of information. So I think this endogeneity, if I am to use a game theoretic term, these actions now become endogenous because are no longer just dependent on the information that is given to them. Clinicians are going to adapt their actions because of these predictions. So I think that looking at the person in the loop, clinician in the loop, would be kind of another area of discussion, maybe.
I think one of the I think I agree with Maxime on I think this is so important, this build of trust, right? Because on one hand, when I say yes, I want to know what happened on my patient, but that is because I'm not fully trusting on the model, right? And why I'm not, so it's different of the signal that you get from engineer system where you know whatever you get in, I mean, you get out without, and different is what we get from the risk models that we build, right? So a lot of time, I mean, it's not that we have the precision that you have with a more predictable system. So I think that because I can see that if I say, oh, well, I don't trust this machine learning algorithm, I want to do this based on my concept of the patient, I can also be increasing the risk of my patient, thinking that I'm going to perform better, right? But I think that is because the systems are not perfect, right? So we know that we can fail because I know that a few days from now, something else can happen and this patient will not do well. I think we're not there in medical or medical data. Probably for some problems that are very predictable, yes. For some others that are more complex, maybe not. I think with, for example, a pulse oximeter, maybe that signal is just more precise, so we are blindly able to trust it. While these almost maybe, I'm still a little bit concerned, which probably in the future that changes. Because I can see, for example, a GPS, right? I mean, I wouldn't even try to beat my GPS. It's very difficult, right? They do so well. And that is because, I mean, they have so much data, so much information, so much that has been learned and fit into that model. And I think we don't have that in clinical care yet, maybe in the future.
Another thing, if I can jump, since your discussion has stimulated me, so not only the focus on counterfactuals and what would have happened if we would have delayed treatment or we would have acted differently, but also what you are all saying is about how these technologies are affecting decision-making in general. The information that you look at, the information that you looked at over time, the response to your actions. So I think that there is an emerging new area of machine learning that tries to understand human decision-making and try to not replace humans, whether it's clinicians or humans or of any kind, but rather augment this intelligence. So maybe again, a potential frontier would be, how can we build better machine learning systems that are working in tandem with an individual clinician, individual nurse, an individual patient for that matter, that needs to make decisions for their health over time. So it is my hope that really machine learning itself can become more of a debugger of our thinking and can prompt us to look at the right information and to make the right decisions by providing us the information that we need to consider in making the decision. And again, maybe that needs to be personalized, because maybe what would convince Maxim will be different than what would convince Hank, for instance. So having this type of understanding of what information is most relevant for an individual to convince them to act in a certain way or to debug their thinking. One could think also not only about convincing the clinician to act in a certain way or providing relevant information, but it could also be a debugger. So as somebody decides on a particular intervention on a patient at a particular moment in time, the machine can say, wait a minute, you make this decision, but have you considered the fact that this patient has this particular characteristic, for instance, as diabetes, and hence is at high risk of these complications that you may have not even realized. So maybe again, for a discussion for a subsequent revolutionizing healthcare, but how can we build better recommender systems that are considering the individual characteristics of the clinician and of the patient maybe? It's kind of almost a next discussion. Yeah, Harpreet.
Thanks, Mihaela. I think that's a really interesting insight. I guess the challenge is, being a primary care physician in the NHS, how do we then translate that into that setting? Because there is a big knowledge gap amongst many clinicians, and I think that's been talked about earlier today as well. And how much do we need to know? And I think that's quite important, is that, there's one is the clinical application, and then from the knowledge and skills is how much do we need to know? Because not everyone is going to be well versed in that. Not anyone could treat the interpretability models. And so I think there is quite a significant chasm there for us to cross. And I'm not quite sure what the building blocks are there for us to get over that, essentially. I don't know if the panel has also some opinions on that.
But I can follow up on these comments, plus there is a comment in the chat on is machine learning changes clinical practice, then it may make it obsolete, right? So, and I think it relates to, so you have clinicians working clinically with their current framework, then you bring a technology that suddenly substitutes to the clinical expertise. And then that's what you, Mihaela, discussed about, like the relationship between the clinician and the technology, and the technology should. But I would argue that this is not specific to machine learning and artificial intelligence. That's been true for every technology we've had in medicine over the years, with the fear that these technologies will take over and replace us. For example, again, going back to the pulse oximeter, which is one of the most ubiquitous technology in the medical setting. Before the pulse oximeter, clinicians were able to diagnose cyanosis in a patient by looking at the color of their skin, the color of their lips, except that for a clinician to learn this skill, it would take months or years. When the pulse oximeter arrived, within 5 minutes, you teach a resident or an intern, if the number is below 90, the patient is cyanotic. However, you have to be careful. If the waveform is not a good waveform or whatever, you have to be careful in how you interpret it. Very quickly, the technology became ubiquitous, right? But it did not replace clinician. It didn't make clinical practice obsolete. Artificial intelligence is going to be the same. It's going to be working with clinicians. It's going to help them on their decision-making, the clinical decision-making, not the actual clinical skills, not the actual diagnosis. It could, but it's not going to replace clinician, because there is a part of medicine that's not like analytical. It's a part of medicine that's the humanism as a healing power, right? And so that you may not be able to replace it. But there is one thing that I haven't seen with machine learning, is that we've been discussing it for 5-10 years, but I yet have to see a technology that's been embraced by everyone. So, and that's going to be the ultimate test. If a technology is useful for clinician, it's going to be embraced. And so far, I don't know of any technology using machine learning or artificial intelligence in medicine that's been embraced. So far, it has not delivered as much as we expected. So we can talk about how this is going to disrupt clinicians and so forth, but I still have to see a delivery about this field. I still haven't seen that.
Yeah. Sorry.
Can I comment on that one? Because I think that what would help machine learning in being accepted is that it solves a real troublesome clinical problem. And if we would be able to solve a real existing and great clinical problem with machine learning, then everybody would be prepared to use it. And I think that there are lots of examples you can think of where machine learning can really help society, patients, and clinicians. And that is what we should be looking for if you like to introduce machine learning in clinical practice. A real good success. That always is helpful, but I think especially for machine learning at this point of time.
Yeah.
Thank you very much. Maybe we can keep a little bit later subsequent questions. So yeah, so thank you. On this note, I completely agree. And I think, Maxime, part of the reason we have these discussions is to identify both what good problems are there, but also what technology needs to do, what machine learning technology needs to do to provide you the right tools that you will find useful. And I think it's a long journey, unfortunately. Thank you for this discussion. We had some other questions that we received, so that's the reason I kind of wanted to interrupt the current discussion, which is wonderful, and I thank you for participating. Nick, you wanted to move on?
Yes. So I think we do have a question from Teaming, and this was sent to us between sessions, as well as a few others. But if we could start with Teaming, that would be fantastic. And I think also we will shortly be losing Maxime, who's generously volunteered his time, but will have to leave somewhat soon. So Maxime, thank you so much for joining us. Really appreciate it.
Thank you very much.
Thank you so much for the exciting discussion so far. So this is Tim, and I'm a clinician in training from Cambridge. So I'm very interested in the point brought up by the discussion just now, which is about we have been focusing on improving the models, but just to think outside the black box, if patient outcome were to be determined by both clinicians and models, how should we prepare the clinicians to actually improve the healthcare outcome? So love to hear panelists' opinion on this.
So I don't know, Alex, Martin, or Henk, or anyone else.
I'm sorry, I don't think I quite understood your question. Could you repeat that for me again? Sorry.
Oh yeah, sure. So the question is really, we are focusing on improving how to improve model interpretability, how to fit models to clinicians. And then what do we need to do on clinician side so that models and clinicians can work best together?
Okay. Well, I'll have a start. I think which comes partly back to Henk's point, I think that first of all, machine learning should be trying to address issues that clinicians feel are important. Okay, they're the ones who should be generating the questions, and then machine learning should be able to should be trying to demonstrate whether they can answer it better than our current methodologies. That's why you have to have the primary question needs to come from the clinician. If you do that, then they will already be primed to want to have a better way of trying to address a clinical issue and seeing whether machine learning can do that. I think part of it will be education. Will be trying to train people so that they can understand not just machine learning, and I think that was Maxime's point, but how they understand the benefits of technologies, whatever the technology may be. Machine learning is just one of those technologies. How we understand technology better is not part of standard medical education at the moment. It needs to be. We need to improve our understanding of that. And that, I think, will again lead us on to ask the question about how do we generate trust in technologies. And that is an area which I don't think has been very well researched for a start. So I think that would be something that we need to try to work out. Why is it that some clinicians are more trusting and others are less trusting? What are all the different components? I've tried to explain some of them before, that we need when in order to say that we do trust something. This is something that philosophers have discussed as well. You know, what is the philosophical basis of trust? It's like asking the same question as what is the philosophical basis of beliefs? I mean, William James, the great philosopher, said, you know, there are always going to be two components to it. First of all, you have what he described as presentational immediacy, how it immediately grabs you. And then there's also philosophical reasonableness, which is what comes after it and which we often lay onto it. We need to think about all those different things when trying to work out how we introduce machine learning and prepare the ground for clinicians to understand it.
Thank you.
Yeah, maybe something else. Tim, are you a clinician?
So right now, student doctor. Yeah.
Okay. Which rules do you use in practice?
Which tools? So
rules. Which clinical rules?
Rooms.
Rules.
Oh, rules.
Rules.
Like the NHS guidelines.
Because there are a lot of clinicians. Almost all clinicians use rules from the past. Now you use Wells rule to judge whether somebody is at risk of pulmonary embolism. You use the Church-Vask rule to decide whether somebody should be using anticoagulants when he has atrial fibrillation, and so on and so on. I mean, that is machine learning is not so different from those rules. So when do clinicians use rules? When they think they can profit from it. And what also helps is their peers ask for them, did you think of using that rule?
Okay, thank you, Tim-Ming, Alex, and Henk for addressing those. I think we have a couple of questions that we received from Venkat, one of which was sort of by email between sessions, and I think you also have one or two questions sort of specific to this session as well. So do you want to go ahead and raise those for the panel? Or for
Hi, I'm Venkat Reddy. I'm a neurodevelopment pediatrician from Peterborough and Cambridge, very nearby. And also I'm Officer for Digital Health and Technology for Royal College of Pediatrics and member of Digital Health Network of Academy of Medical Royal Colleges. I say that because we are grappling with this on behalf of the various Royal Colleges, trying to write strategy for digital health and AI at the moment. And that's why I've been talking to Mihaela quite a bit. And also Harpreet, you will be delighted to know that last residential at NHS Digital Academy was all focused on ML and AI and ethics of it, really, I think. So my question was that I think some of it we touched on just before, really. I just saw a parent, Arabic parent, who was worried about autism. We done autism assessment, gathered information from parents through interpreter, from the child, from the nursery, myself, and I was trying to explain to them how I came to the diagnosis of autism. And they're telling me that, oh, but in my culture, we don't give eye contact, children don't look at it. So I have to go through 30 features of autism diagnosis and explain how much weight I put onto each one of them, how did I come to that conclusion. And this is not something clinicians are expected to do all the time, and we use our shortcuts and type 1 thinking, type 2 thinking. And are we expecting machine learning and AI algorithms to be even better than humans at explaining themselves? Because we give very difficult news for parents in 10 minutes and don't explain. That's my question, really. Are we expecting the AI and machine learning to be even more explainable, even more transparent than human clinicians?
I'm sure that Alex and Henk and Martin will have something to say, but just from my point of view, I think one potential use that we have not covered here, but maybe we can in a future session, I see machine learning indeed as a tool that can help the clinician. And maybe one thing it can do is can provide a variety of explanations for the current situation. So not only make predictions and maybe better predictions or better recommendation than a clinician, but also can provide knowledge. So going back to Alex's more philosophical discussion, maybe can provide an entire set of hypotheses and information at the fingertips of the clinician to select from and to consider in their final decision making, whether it's for the explanation to the patient or for something else. So I almost feel that machine learning could hopefully generate this type of additional knowledge that you clinicians can use. But I don't know what you think, Alex, Henk, and Martin.
Yeah, well, I think that for many decisions clinicians will have to make, they must use so many variables that in fact our brain can't handle that. Yeah. So what we do in those cases is we throw away some variables so that we keep just enough to think what they can do for this patient. And most of the time, that means that we don't use all knowledge that is available. So in that sense, clinicians are not so good. And in a sense, computers can do it better. And we have to accept that that is the case. I think that that's a very important step to take. That doesn't mean that you have to follow the judgment of a computer without any question, because there will always be some humanity in taking every decision you take, for example. But it can help you tremendously if somebody helps you to get some control over all those variables. Sometimes. Is that?
I fully agree, really. I think there is already algorithms looking at how many features you need to make a diagnosis, as well as a clinician about 8 or 9 features are enough, and that can be done in 20 minutes rather than we're spending up to 15 hours and a waiting list of 2 to 3 years. And that could be the second person, similar to the mammography screening, where I still want to make the final decision, but that's another input. ML/AI is another input, along with the nursery report, parent report, and the speech therapy report. That's the way I look at it, really, I think.
Yeah, you gave a great example for this, by the way.
I want to say, actually, you inspire me, Venkat and Henk, to throw at you another thought. Do you think that machine learning may allow you to not only communicate better with patients, but also with each other? So maybe if you have a fellow clinician with whom you need to collaborate to be able to better treat a patient, you may be able to explain to each other. So right now you may write a little note with a few words, providing a diagnosis, and this diagnosis is provided to your colleague. But if you need to work together as a team for maybe more complex diseases or diagnoses, this would allow you to machine learning can help you kind of make your decisions and your predictions more accurate and more quantifiable.
Very much so, Mihail, because we have got another analogous example we use in our neurodevelopmental practice. If you look at ADHD diagnosis, until recently, it's all qualitative information from various people about level of inattention, hyperactivity, somebody says something. Now we have a program, a child sits in front of computer, does a 20 minutes boarding task that gives us the 95th centile for attention, hyperactivity, impulsivity as a graph. And once we got that one, it's a lot more easier to explain to, we still take the views of the child and the parent and the teacher and we see them, but there's something objective adding into that has made our life a lot more easier to moderate and umpire between two parents who give us diametrically opposed or subjective view of the inattention and hyperactivity. And ML and AI could be helping us like that, really. But I still need to be in control. I still need to be able to explain my decision and see how I use the recommendation from ML in that process, really.
I was also going to interpret your question in a slightly different way, because I thought what you were meaning was, should we hold clinicians who make decisions to the same standard as we hold machine learning platforms? And if that's the question, then I think the answer is yes. And indeed, one knows of many clinicians who may make decisions that I may not trust. And some of the reasons for that is because they can't explain why they make that decision. And if they can't explain then I don't necessarily trust them so much. So I think we have to hold ourselves and the machine learning to exactly the same standards.
I fully agree with you, Alex. I think that's why we're moving away from expert-based medicine to evidence-based medicine. But and we all need to be trained equally at critically appraising a paper as we are in an algorithm and looking back at the sample size and sample selection. Does it represent and all those things? They're exactly the same. We need to transferable skills, really.
I think that I see that there is a question in the chat which is about this, which is to the degree to which platforms that may give a contrary decision to what the clinician feels, will that engender trust? And indeed, it's easy to trust something when it says that I'm right, but it's much harder to generate trust when it says I'm actually wrong and completely in the wrong direction. So we do need to use it really intelligently. But my view is always going to be that if the platform has been shown to be demonstrably better at getting to a diagnosis or getting to a prediction, then they should be the support tool that we're looking for. It should say, be careful. Are you absolutely sure you have got it right this time? We think that you may not have taken enough note of these particular factors, in your decision process.
So maybe
that's very much so. It's very much so, because that happens with the human clinicians now. I got a multidisciplinary team of pediatricians, psychologists, speech therapists. they do a joint assessment and come to diametrically opposite conclusion about the same child at the same point, and you send them for second opinion, you get something entirely different. So I think it's just a red flag to think, stop and think again, really. I think.
We have exactly the same in my area, where we have weekly meetings with clinicians about who should or shouldn't have a liver transplant, who shouldn't have multivisceral transplants, and people will all come to different decisions, but there are empirical answers. And maybe machine learning can help us understand why our gut feelings
and converse better. Maybe hopefully machine learning can help you converse better and arrive to a conclusion and understand better the basis of your decisions and help you debug your decisions. I guess on this note, and given the time, maybe it's good to wrap up.
Yeah.
And, we would be delighted to take subsequent questions in the future. So thank you very much.
Yeah, so sorry, I think there are a couple of people I may have promised a couple more questions to, but we've kind of hit our time limit now. And I think it's very much worth it for the conversation that we had. And sorry, we couldn't take them all. But if anyone else does have any questions, I think they can just send them to us separately via email or something like that. And we will try and get around to them. So, Mihaela, I don't know if you want to wrap up with a couple final words, or if I should just
wanted to thank very much to the panel and everyone who participated. I thought it was very interesting and a lot of food for thought for us, the machine learners, to build better tools to better serve you, and hopefully for you to sharpen your thoughts as to what you need the machine learning methods to demonstrate to convince you to use them in practice. So hopefully this discussion has helped our understanding on the two sides of the table to build better tools that truly can empower you and help you even converse better with your colleagues, not only the patients.
Okay, and yeah, just before I leave you, I would just like to share a couple details regarding our upcoming session. So our next session will be in early June. We're tentatively looking at June 5th at the same time as this session today. The focus will be on individualized treatment effects or personalized therapeutics. And we'll be sharing out some sort of resources for you to have a look at ahead of that in the sort of weeks between sessions. We will be planning to maintain this roundtable format as we proceed. And just a couple other quick notes. So for those of you who would like to claim CPD credits, you can just drop me an email at the address you see on the slide here. Please just let me know which sessions you've attended and how you attended them, whether you attended them live or whether you watched the sessions on YouTube. And then I'll prepare a CPD certificate that I'll share with you, and you can apply via the RCP's website. And in the meantime, if you do have any friends or colleagues that you think might be interested in joining these sessions, please do let them know via the URL on the slide. Obviously, our aim is to build a community, so word of mouth is very important in helping us sort of achieve that goal. And lastly, I'd just like to give a big thank you to everyone who joined us today, to everyone who asked questions. And I'm sorry again that we couldn't quite get around to all of the questions that were asked. But we did, I think, have a great discussion around the questions that were asked. And I'd especially like to, of course, thank our panelists who devoted some time from their extremely busy schedules to be with us today and for sharing their thoughts and insights. And in the meantime, I look forward to seeing you all again in June. And please take care and stay safe. Thanks again for joining us.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye.